I'm going to be talking to you tonight about the management of acute ankle injuries in footballers from a clinician's perspective. And I'm aware of the fact that this audience most likely already has a lot of experience with managing football injuries. But what I really want to do for the next 6 minutes is to concentrate on the points of difference we need to consider when we're dealing with professional footballers as opposed to the general sporting population. But first, why are we talking about ankle injuries in football in the first place? Because it makes up to 30% of all football injuries and up to 12% of time loss injuries. So it is a significant problem. And if it's left untreated, 40% of those with an ankle sprain may end up with chronic instability or osteoarthritis. And it's really sad to know that up to 6% of ex-professional footballers already have ankle arthritis. So the first consideration is the mechanism of injury. The mechanism is important because it determines which structures are going to be injured. And specifically, we know that foot pronation combined with external rotation can result in syndesmosis injury. And we have to appreciate that the ankle joint is actually not a true hinge joint, even though some authors would suggest that it is. And if you look at the ankle prosthesis, you might be forgiven for thinking that it is a simple hinge joint. But the reality is that the talus can rotate in the mortise, and this is where the syndesmosis is at risk. So the reason this is important is that we know the mechanism of injury in football is different from that in the general population. In sports like cross-country running, for example, the majority of ankle injuries will be straightforward, non-contact inversion injuries. But in football, the mechanism depends on the position of the player. So whilst in up to 80% of goalkeepers, they will have a non-contact and most likely inversion injury, the same is not true for field players. So we know that up to 2/3 of field players will have direct contact injuries, such as during a sliding tackle, and often from the lateral side with an eversion mechanism of injury. So it's also important to note that almost half of those will have a pronated foot at the time of the injury. So if there's an element of rotation as well, then the likelihood of a syndesmosis injury increases significantly. The difficulty, of course, is that the history we obtain from the patient is often very unreliable. But here's the first little bit of luxury we have in professional football. The video replay is not. So my advice would be that if there's any recording of the match, it's absolutely worthwhile trying to find the footage, looking at the mechanism of injury, and if there's any eversion or rotational element, you should have a high index of suspicion for a more significant injury. The second consideration is imaging. So we've known for some time that the examination of an ankle sprain in the first 48 hours is unreliable. And we know this is because of swelling, pain, and perineal spasm, for example. So therefore, the first visit in the first 48 hours is not really to make a definitive diagnosis, but it's rather to act like a triage. And what we want to do is exclude significant injuries like fractures, and we want to protect the ankle with some form of brace or boot. We also know that the incidence of ankle fractures in football is actually very low, 5%, as opposed to, say, 15% in the general population. But here's the problem. I think we'll all agree that footballers are not normal people. Not only is football the profession for footballers, but they're also very expensive assets for their clubs. So as a sports physician, you can't afford to miss a fracture in this group of patients. So even though we use the Ottawa ankle rules in the emergency department to determine who needs to have an X-ray and who doesn't, we have to be aware of the fact that the sensitivity of the Ottawa ankle rules is actually not 100% as first reported. These rules were developed by a Canadian emergency physician in an effort to save costs in a public health setting. And clearly, professional footballers do not fit in this setting. So it's my opinion that in the case of professional footballers or any other professional athletes for that matter, we shouldn't be using the Ottawa ankle rules as part of our standard assessment, because cost is not an issue in this group and we can't take the risk of missing a fracture. So similarly, we should be aware that even though the delayed examination can be very valuable, there are still some limitations. So both delayed physical examination and ultrasound have a higher sensitivity for diagnosing ligament ruptures and particularly lateral ligament ruptures. So we know that if you have a combination of bruising and tenderness over the ligament, and then you add a positive anterior draw test, the sensitivity goes up to 96%. So that's great. But we have to also be aware when it comes to the rest of the ankle, we have to acknowledge that the value of palpation is limited by the fact that many of these structures are very closely related or even overlapping. So for example, up to 40% of patients with ATFL rupture will also have tenderness over the inferior syndesmosis, even though they don't have a tear of the syndesmosis. Similarly, 60% might have tenderness over the medial malleolus and the deltoid ligament because of contusion or compression. And we should remember that when you palpate for the calcaneofibular ligament, the peroneal tendons actually run precisely where you're palpating. So are you palpating the ligament or the tendon? Even the anterior draw test can be misleading because the deltoid ligament, if it's not ruptured, prevents a straightforward anterior glide. So all these limitations need to be taken into consideration. And for me, the most important thing is that we know that there is not a single reliable syndesmosis test or even a combination of tests. We should also remember that patients with lateral ligament injuries often have associated injuries. So in a retrospective MR study we've done in Aspetar in 2014, we found that up to 20% of patients referred for an ankle MR scan after a lateral ligament injury actually had a syndesmosis injury. And these were not just footballers, this was the general population or general athletes, and of course in footballers it might be higher. So the same study also revealed that 8% had osteochondral lesions of the talus, and of course there were lots of bone bruise, contusions, and deltoid ligament injuries. So my point is this: don't hesitate to use imaging early if you are dealing with a professional footballer. We would love to believe that we have magic hands, but the truth is we just don't. And in the case of professional footballers, they usually need a definitive diagnosis, and they need it like yesterday. So the third consideration is that treatment should be individualized. Even though most clinical guidelines would recommend early functional rehab for lateral ligament injuries for all grades, professional footballers with grade 3 ruptures are often referred for surgery. So this is still a bit controversial, and we don't have enough time to discuss this in this particular talk, but we need to use a shared decision-making model when we discuss this with a player. My last point is this: we should not forget that no two players are the same. We are just starting to explore the differences between men and women in football medicine. But one thing we already know, and that is that one size definitely does not fit all. So to summarize, when dealing with professional footballers, we should consider the mechanism of injury, facilitate early imaging, and ensure we individualize the treatment. Thank you.